So I'm very excited to introduce our next speaker, Dr. John Lynch. He is the medical director of Harborview's Infection Control and Antibiotic Stewardship and Employee Health Programs. And today he will be talking to us about antibiotic stewardship. So I'd like to hand it over to Dr. Lynch.
Good morning, and thank you, Mayor, and thank you to everyone for the very kind invitation to present today. I'm going to try to do this actually
Is he frozen for anyone's screen?
Yes. Dr.
Yeah.
Lynch, you're frozen.
Yes.
We'll probably give it a minute.
Sorry. Mayor, can you hear me?
Yes, but you're freezing up a little bit.
Ranging from issues around can you hear me either? Mayor, can you hear me?
I can hear you now.
Medical Center in Seattle, Washington, County. Some of the really important all in, sorry. Mayor, how's that? Is it working at all?
Yeah, it's working a lot better.
Okay, I'm so sorry, folks. I do not know what's happening. Everything
It's
was
okay,
good.
don't worry about it.
Okay, So I will accelerate this a little bit. So I'm going to talk about 3 different pathogens today, and I'll count on folks to ping me in the chat if my voice is breaking up. So the 3 pathogens I'm going to talk about are Candida auris, a fungus, Ebola virus, and mostly the 2014 Ebola virus outbreak. And the third one will be NDM1, which is a gene that's been linked to highly drug-resistant bacteria. So a fungus, a virus, and a sort of bacterial gene. So the first one I'm going to talk about, because it's actually quite topical and relevant right now, is Candida auris. Candida auris is a fungus that was first described in 2009 in Japan. It was actually cultured from a person's ear, hence the name auris. But in retrospective studies of bank specimens, there's probably first isolated in 1996. What's fascinating about this particular pathogen, and I'll get to the impact on humans here in a minute, is that it appeared to emerge in multiple parts of the world simultaneously. So there's been detections in different parts of the world, in different bank specimens, in different patients, that didn't appear to have any connection to other parts of the world. So this first described one in a clinical specimen in 2009 was in Japan, in this person's swab from an ear, but was simultaneously found in other patients around the world who had no connection to Japan or even in those bank specimens. Saranya, there's no slides. I'm just talking. And fortunately, because I think slides would be a disaster right now. And so the idea here is that this novel pathogen, this new fungus, emerged around the world simultaneously, and we really don't have any clear idea why. There's some hypotheses that the use of antifungals in agriculture may be driving that and selecting out different Candida species. Candida as a genus is a very large group of different fungi, some of which are actually important human pathogens. Most importantly, Candida albicans. This is a fungus that can infect generally people with compromised immune systems due to chemotherapy or advanced HIV infections and similar, and often are associated with things like central lines. These are large lines that are used in hospitalized patients to go into big vessels in their chest, their groin, or their neck, and similar. What's been really interesting about this particular pathogen and why it's a very big concern for us right now are 2 reasons that the pathogen impacts us. One is it is incredibly drug resistant. So when we see people who we think may have a candidal infection or at risk for a fungal infection, we often can treat them upfront empirically with effective and fairly tolerable antifungal medications. But Candida auris is often resistant to those drugs. And so what we see is as this pathogen now spreads around the world, it's now in over 30 countries and has been seen in over half the states in the United States. What we're seeing is that people who have this as a colonizing pathogen or as an infectious disease pathogen, that particular organism is not susceptible to our typical antifungal empiric treatment. And so this is a big deal for us because we've never seen anything like this. It has not been seen anywhere else in the world until the emergence of this new Candida species. The second part of it that's been very challenging is that it is very environmentally sticky. So it sticks to every place in a patient's room. It sticks to the shelves, the phones, the TV controllers, the beds, the doorknobs, and so forth. And as a result, can be easily moved from one patient's room to another patient's room. That environmental contamination then leads to colonization of the person. And then if they are susceptible, either through being immunocompromised, immunosuppressed, or having central lines or other invasive devices, they can now become infected. And once infected, the mortality rate is extremely high, ranging around between 50 and 60%. So once these infections actually occur, in part because of the pathogenicity of the pathogen, but also because of its drug resistance, it has become a bigger and bigger problem. And here in the United States, where I'm working, we're seeing very large outbreaks right now in Nevada and in California on the West Coast, but there have been prior outbreaks in the Midwest and also on the East Coast. And what's really challenging is that in addition to its drug resistance and its environmental contamination or stickiness, is that it's very hard to actually detect. And so it looks like a lot of other candidal species, and unless you're actually looking for this particular pathogen, you may not catch it, because people are often colonized and many labs aren't paying a lot of close attention because this hasn't been a typical pathogen. So this is one of the big trademarks of emerging pathogens in healthcare, is that until we start looking for them, we don't know that they're actually there. And that's what's really driving the transmission in these big outbreaks in the Western United States right now, in both acute care hospitals, so what we think of as a typical hospital, but also in long-term acute care. So these are facilities that take care of patients who still are recovering from acute illnesses or require ongoing high-level medical care, and even in nursing homes where people are residing for long periods of time. And what we're seeing is transmission back and forth between individuals within those settings and then between settings. Again, without any evaluation of their colonization status, and only really detecting it once people have acute infections. And so I fully expect to see this pathogen spread to every state in the United States, and at some point will likely be seen in every country in the world. And that's going to create a significant problem, because it is this very high lethality rate. So it's a very dangerous pathogen. And in part, that's being driven by drug resistance. And the fact that this emerged in multiple sites simultaneously around the world, I think is a strong indicator of environmental pressures, probably the use of antifungals in agriculture that led to selection of drug-resistant fungal species, then moved into the human environment. So that's just one thread here that I wanted to touch base on so that people have heard of it and are aware of it. The next thing I'm going to talk about briefly is a gene that we see in a group of bacteria that we refer to as Enterobacteriaceae. There may be microbiologists on this call, and so I'm not a microbiologist, so I'm going to, feel free to correct me as I go through this, but this large group of bacterial species are lots of different bacteria ranging from Klebsiella to E. coli, many of which actually live within us as sort of, co-organisms living together in happiness, but can be opportunistic pathogens. So when we get sick, when we're in the hospital, when we get surgery, when we get one of these big central lines put into place, if we're not careful, those pathogens that are, or potential pathogens, can move from our guts into other parts of our body, leading to disease. In general, when we see these types of things, we're able to, again, treat people with empiric, so best guess antibiotics, and then focus on the specific bacterial species and the drug susceptibility profiles to inform us about which antibiotics are going to work. What we've seen, in my time as an infectious disease doctor over the last 20 years, is just the increasing detection of drug-resistant bacteria. And I think we've all heard about these, and we've heard the term superbugs and similar. But what we often see is, instead of what feels like incremental increases in drug resistance, are actually more like step functions, where we see the emergence of specific genes or combination of genes in different bacterial species or groups of bacteria that lead to big new challenges around drug resistance. And I think the NDM1 story is a really important one. Now, there's multiple reasons why this is important. The first thing I'm going to say is, the name of this gene is an unfortunate choice, and I'm hoping that we will eventually see a new name, but it's the name we have right now. It refers to a gene that's called the New-Delhi metallobeta-lactamase 1. It didn't arrive in New Delhi. That's not where it originated, but it was first described, and there are ongoing conversations about the appropriate naming of this. And it's actually one of the genes that sort of started the discussion around how to appropriately name different pathogens that aren't linked to specific sites. So I'm just going to refer to it as NDM1. Why is this gene really important? It is a plasmid-mediated drug resistance mechanism. What that means is that these little circles of DNA can move between different bacteria, not only within a species, but within different species of these Enterobacteriaceae. Many bacteria are quite promiscuous and be able to move different genes back and forth, especially plasmid-mediated genes. And NDM sits on a plasmid that moves between these different bacteria. NDM on this plasmid conveys complete beta-lactam drug resistance. So when we think about beta-lactams, these are our biggest and broadest and most important antimicrobials, including drugs like carbapenems, which are often our last go-to sort of rescue drugs for very serious and drug-resistant infections. What's interesting about the NDM1 stories, when this was first described in outbreaks in 2009 and 2010, particularly in the original studies were done in India, was that this particular plasmid in these different bacteria were running sort of in a bad crowd. The same bacteria that had this plasmid also tended to have other drug resistance genes. So resistance to things like trimethoprim sulfamethoxazole or Bactrim, or fluoroquinolones like levofloxacin. And the problem then is that what we started to see was the emergence of essentially pan-resistant bacteria that were very commonly seen in hospital-acquired and even community-acquired infections. And so as this spread, we lost this opportunity to be able to treat people effectively with our go-to, even when we suspected highly drug-resistant infections, we started to see failures of that. And the real challenge with drug-resistant pathogens is not only sort of the primary failure of the drugs that we typically use and what works for us, but also that we have to then rely on older drugs that tend to be more toxic and less effective. And so to give you an example of this, I took care of the first patient with an NDM1 containing bacterial infection here in Washington State back in 2010, 2011. It took us, about 14, 15 months to treat him. And during that time, the combination of drugs I had to treat him with led to kidney failure, led to loss of his white cells, led to extreme weight loss because he was so nauseated. Now, all these things, fortunately, because of his youth and otherwise good health, was able to recover. But it also led to repeated need for treatment. So we would treat him, the infection would come back, he'd have to get more surgery. We treat him again, more surgery. And then eventually we just hoped that the combination of drugs we're giving him would be tolerable. And we just based it on the level of toxicity. And I think to some extent got lucky with a combination of surgery and a combination of fairly toxic drugs to treat him. And he's done well since then. But if we were to think about very large populations of patients with that same type of infection, it would be incredibly, intensive for all of us to take care of patients with that type of challenge. Like Candida auris, the NDM1 gene has been seen throughout the world now. Like other bacterial resistance genes, it moves back and forth between countries as a colonizing pathogen, as an infectious disease pathogen, as people move between different healthcare facilities in the world, and similar. And so now it's been seen throughout the world and in many, many different countries. So I've talked about Candida auris, and I've talked about NDM1, so a fungus, and I've talked about a bacterial gene. The last thing I'm just going to touch base on isn't so much a drug resistance issue or antibiotic stewardship issue, but I think ties together some of the elements that have already been discussed this morning and will be discussed later in the day. And that's around the impact of emerging infectious diseases on healthcare. And I'm going to talk about a virus, and I'm going to talk about Ebola, the 2014 Ebola outbreak. And this may feel distant for some folks who weren't part of that outbreak, or who didn't live in the countries that are majorly impacted, namely Guinea, Liberia, and Sierra Leone. But we know for those of us who were responding to that outbreak, that this impacted a lot of elements of healthcare in our public during that time. So just a brief review, in 2014, there was an outbreak of Ebola in Guinea, in the country of Guinea. And what was different about this particular outbreak was that often these Ebola outbreaks were isolated to fairly rural areas, and to some extent that they were able to limit transmission because of public health efforts by those countries in those rural areas. But what we saw very early on was the movement of people from rural areas to very densely urbanized areas in the setting of Guinea into Conakry, and people moving back and forth as they move from rural to urban, urban to rural, and also moving across borders. And we started to see that transmission occur in Liberia and Sierra Leone. And why this is really important when we think about drug resistance and emerging pathogens, and in my area, how this impacts healthcare, is that as people moved into healthcare facilities, we started to see sort of adding to that transmission. So with sort of the lack of the ability to do appropriate infection prevention, both in the public arena, but also in healthcare, we started to see transmission occur in healthcare facilities and started to see that as sort of an accelerator of that pandemic, which led to further breakdown of infection prevention. And so what we saw with the Ebola outbreak in 2014 was the first time of really seeing urban spread, movement across borders, and the impact of hospitals. And I think really portended a lot of the things that all of us experienced during the COVID-19 pandemic, sort of this lack of trust in public health responses, and in the government responses, and in the safety and security of healthcare work. And so when we think about going back to the Candida auris situation, the use of antifungals in agriculture, and the movement of patients who are colonized infected across borders and impacting healthcare delivery in different areas, the impact of a single gene, NDM1, in different bacterial species, and that again moving across borders, across the world, and thinking about Ebola again, how patients with either exposed to or infected with Ebola move to different countries in the world. I think what we're really seeing is a set of thematic elements that are super important for any of us interested in healthcare delivery or the health of humans going forward. What we're seeing is, in the world, fairly unrestricted antibiotic use in animal agriculture, non-animal agriculture, i.e. antifungals in plants and similar. The impact of, lack of access to healthcare, and in some places, in many places in the world, fairly weak healthcare infrastructure, and that leading to breakdown in infection prevention. So how do we keep people from getting a new novel infectious disease, whether it's drug resistant or not, in a healthcare facility when they're coming for help? It's fairly unrestricted antibiotic, antifungal, antiviral usage across the planet, which has led to selection and emergence of novel drug resistant pathogens, including these which contain NDM1. Travel, people are moving throughout the planet constantly. And if you are colonized with something, you may then, that colonizing pathogen may move onto other people. And if you are sick with something and move to another country, people may not know it until it's too late and that pathogen is moved around. Underneath all this, I think there's been significant challenges with trust in public health, and I think that's been accelerated through the COVID-19 pandemic. And then underneath all of this, and at a much higher level, is this really change in what we consider our ecosystems, right? The One Health concept is critically important. What we're doing with animals, what we're doing with both in agriculture, but also in wildlife, and what we're doing with our ecosystems and our own healthcare is critically important. Just to sort of put a point on this, the 2014 Ebola outbreak happened with 1.5 or 2-year-old child who interacted with a bat, right? And led to this massive global impact. Obviously terrible for that child, terrible for that child's family and that village. But you can see it takes very little to break down what we think are these strong barriers to emergence of new pathogens. And I have to say, over the last 20 years of my career, compared to the 20 years before that, and talking to my colleagues and reading the history books, it has been fairly unprecedented. And to think that, COVID-19 is our last hurrah on this is maybe lacking humility. And so I will stop there and open up for questions. Sorry for the internet challenges, Mayor, and everyone else.
No worries, Dr. Lynch. This was such an amazing presentation, and it was just I really loved how it was so integrative with so many concepts from public and global health, and it's really a testament to how interdisciplinary the medical profession has become. So I see we have some questions here. I see Akanksha has a question. Go ahead.
Hello, Dr. Lynch. That was a very informative talk you had there. I just want to ask, so is it a Candida auris? Is it a very commonly hospital-acquired fungal infection? And if it is very commonly hospital-acquired, like, what are the prevention we do for it? Like when we have we have a lot of prevention for like even C. diff, like since it's very common. So what are the preventions? Like what are the steps we do to prevent it in immunocompromised patients, especially?
Yeah, great question. So it is right now, it is a major, where we see this happening is in healthcare. So fortunately, it is not widespread in the world, not widespread in the United States, but it is there and it will eventually become much more widespread. But where it is happening in healthcare. And so the interventions in healthcare are one, identification, if at all possible. So where we see this, we want to do widespread screening. And that's a challenge because most facilities don't have the laboratory techniques to do widespread screening. And screening involves swabbing nose, axilla or armpits and groin and getting the right fungal tests, which take time. The second part is what I would say are contact precautions. So very clear identification of patients, putting them into a space where people are excellent around hand hygiene, using gowns and gloves. There's no data behind this, but the idea here is we have a very sticky pathogen. It sticks to environments, it sticks to hands, it sticks to equipment. And so we want to limit that stickiness. The next thing is around environmental cleaning, and particularly not only the space itself, but also shared equipment. People may not realize, but equipment goes between patient spaces all the time. A lot of equipment is very expensive, it's limited. And so we have to bring it from one place to another. But then we have to rely on systems, policies, protocols, and obviously human behavior to clean. And so cleaning is incredibly important with prevention, not only of the patient space, but also shared equipment. And, again, there's not a lot of science behind this just yet. So it's all sort of common sense. And we, I think, are trying to figure this out. The challenges in many places, the ability to put all of those measures in place are very difficult. And that's why we see more outbreaks in long-term acute care facilities, which tend to have lower staffing, and skilled nursing facilities, which have even less staffing to do work like cleaning, screening, and surveillance.
Thank you so much, Dr. Lynch.
Thank you for clearing my question. Thank you.
Of course.
Yeah, I don't think we'll have time for another question, but this is really amazing, Dr. Lynch. Thank you so much for your time.
Oh, of course. Thanks for having me on. Have a great day, everyone.
You too.